and thanks for tuning in today. I'm Amanda. I'm one of the pharmacists at Eastmead Pharmacy, and in this session, we're going to look at two key areas of medication management: controlled drugs and PRN, or as required medicines. These are both high-risk areas that require careful thought, good systems, and clear documentation to keep our residents safe. We'll cover what the legislation and guidelines say, talk through some examples, and look at how good communication and teamwork make all the difference. Whether you're an RN, EN, or caregiver helping with medication rounds, every role in the process is vital, and you're part of that safety net. I'll preface this to say that what I'll be talking about is the minimum recommended processes, and many facilities have processes and protocols which are more comprehensive, and these should be followed as first line. By the end of this session, you'll be able to understand what controlled drugs and PRNs are and the specific risks that come with them, apply the 5 R's plus 3 to ensure every medicine is given safely for the right reason and is documented properly. You'll know who can administer controlled drugs, how witnessing works, and what's required in the register. And you'll recognise how PRNs should be prescribed, administered and reviewed, and when to escalate if something doesn't look right. And finally, we'll work through some real-life case studies that highlight where things can go wrong and how to prevent it. This session isn't about adding extra paperwork, it's about clarity, confidence, and consistency. The Medicine Care Guides for Residential Aged Care from the Ministry of Health are our backbone for safe practice. Even though they were published in 2011 and are currently under review, the principles remain the same: safety, accuracy, and a resident-centred approach. They remind us that medicine administration is part of the wider care plan. It's not just a task. It's about asking questions like, why is this medication being used? Is it still needed? Is it helping or causing new problems? And with controlled drugs, we're often balancing pain control with side effects like sedation, constipation, or confusion. So while the guidelines give us structure, they also remind us that good practice starts with clinical curiosity. This is an overview of medicines administration in aged care, and I won't go through this flowchart thoroughly because it is found in the Medicines Care Guide, but I wanted to point out the importance of the 3 R's plus 3. It should be done at least 3 times during the administration process, and it's a crucial element to medication safety and accuracy. Many of you will be familiar with the 5 rights plus 3, but they're worth revisiting because they're the foundation of everything we do. And they cover the right resident, the right medicine, right dose, right time, right route, right reason, right indication, right to refuse, and right documentation. So moving on to controlled drugs. And what are these? Controlled drugs are medicines regulated under the Misuse of Drugs Act 1975. They're divided into classes. So Class A is the most restricted, things like heroin and cocaine. Class B, morphine, oxycodone, fentanyl. These are the ones that we probably deal with most regularly. And Class C are lower risk, like codeine, but still controlled. They're called controlled drugs because of their potential for dependence, misuse, or diversion. And that's why every part of the process, from prescribing to disposal, must be traceable and documented. For us in aged care, controlled drugs are mainly opiates for pain or palliative care, or sedatives for symptom relief. They can be beneficial when used correctly, but also a lot of harm if not handled correctly. Controlled drugs are often essential for comfort in aged care, but they carry serious risk. Older adults are more sensitive to medicines that affect the brain and the central nervous system, and a dose that's fine in a younger person can cause dizziness, confusion, or falls in a frail resident. So that's why our systems, the double checking, the register, the documentation, and the monitoring are there. It's about safety. And we, as frontline staff, are the last line of defence. We're the ones who spot when the pain is uncontrolled or when sedation becomes excessive. That vigilance is what keeps the residents safe. So, who can administer controlled drugs? As per the guide, only competent authorised staff can handle controlled drugs. 2 staff are required to administer each dose, and one of these must be a registered nurse. Both check the prescription, confirm the resident's identity, and witness the administration. Both need to write and the entry in and sign the controlled drugs register immediately. And remember, some facilities set even higher standards. So for example, 2 RNs for all CD administrations, or strict key control, and that's okay. You need to follow your guidelines at your facility. But every step, the checking, the witnessing, and the signing adds a layer of protection for residents and staff alike. The Controlled Drug Register is a legal document. It records every movement of a controlled medicine. It records the date and time, the resident's name, the medicine and strength, the running balance, and signatures of both staff members. A few reminders around this. So always write entries in ink, never in pencil, and never use whiteout or correction tape. If you do make an error, strike it out with a single line and then initial it and write the correction next to it. Stock takes should be done weekly with balances confirmed by 2 authorised staff. And sometimes we get problems coming up with the amount of stock through things like quantity lost through dispensing. So that means that if you're pouring out the liquid into a conical flask, you'll lose a small amount of liquid each time. And this should be documented into the Controlled Drugs Register, annotating quantity lost through dispensing. But to avoid this from happening, looking into buying medicine bottle adapters that allow the medicine to be syringed directly from the bottle would help to avoid this problem. And going the other way, there's the possibility of quantity gained through dispensing, and that should also be annotated in the register if you're left it with more in the bottle than expected, and that's often due to drug companies allowing small amount of overage during manufacturing. So accuracy here is really crucial. The errors in the register are quite common findings when they have audits, but they're also completely preventable. So if you're unsure, make sure to ask a colleague or a senior member that will be able to help guide you through that. Looking at storage of controlled drugs, they must be stored in a locked cabinet that meets legal standards. And that means they're bolted to a solid surface and only used for controlled substances. The keys must be kept by authorised staff only, and that's usually a registered nurse or the manager. And the medicine cupboard should be organised. The stock should be separated by product name and strength, and that will help to reduce errors. Of course, controlled drugs must never be borrowed between residents, and that's the case even in emergencies. Each resident's medication belongs solely to them, and it must be accounted for in their name. And at the end of each shift, it's good practice to check the CD key handover and confirm the balances are correct. It takes a minute, but it avoids hours of having to go through the book later. Controlled drugs, they can only be supplied by a valid prescription on either one of the triplicate H572 forms, so that's the controlled drug prescription forms, or through a New Zealand electronic prescription, NZEPS. The supply limits are strict, so for 1 month for Class B medicines, and 3 months quantity for Class C medications, but often they will have monthly dispensings associated with that. It's important to remember that, once again, we shouldn't be borrowing between residents, and that every supply or return must be clearly documented in the register. Any leftover stock after a resident's death or change in therapy must be returned promptly to the pharmacy and recorded as well. And that keeps everyone safe and compliant. So when we look at PRN or as required controlled drugs, medicines such as morphine or oxycodone, they often can be prescribed as when required, and we need to make sure that the prescribing is really clear. So we're looking for specific indications on the prescription, such as breakthrough pain or dyspnea, the dose, preferably not a dose range, and a frequency, not just as required, but a lot of the electronic systems will prevent that. And it must be signed and dated by the prescriber, which is often done through those electronic prescribing systems. When administering a PRN controlled drug, assess the resident first. So why are we giving it now? Record the dose, the time and the reason clearly, often done through the electronic prescribing, and then follow up and record whether it was effective and if you've noted any side effects. Importantly, we can't do verbal orders for PRN doses. It must be prescribed first. And we need to regularly review how often CDs are being used, because if they're being used frequently, it means the prescriber may need to adjust the regular pain regimen or add in a long-acting version of the opiate. So some common issues we see during reviews are controlled drug counts not matching controlled drug registers, and that can often be just a transcription error or doses not being signed off properly. And that's why it's really important to do those weekly controlled drug counts, because it catches it early, that discrepancy, and we can remedy it quickly, rather than several months down the track and we don't know what happened that period of time ago. Other issues are when refused doses are not recorded correctly. So even if a resident refuses a medication, a controlled drug I should say, the entry must still show what happened, and the medicine should be signed back in. If we've got overfilled bottles, as I mentioned, they can cause discrepancies if they're not measured correctly, or we're losing medication due to pouring into the conical flask back and forth. But remember, it is okay to pause and to double check and to ask questions. So we should always be asking and understanding the why and not rushing through this process. So I've got a couple of scenarios that we come across quite often, and I thought it would be a good idea just to have a think through this and how you would approach the case. So the first one is when a 10 milligram dose of Sevrodol is signed out of the controlled drug register by two staff members, one a registered nurse, but after approaching the patient, they refuse it. So what would you do in this situation? I'll give you a minute to think through. So in this situation, we would record the refusal in both the medication chart and on the controlled drug register. If the dose is still intact, for example, if the tablet is still within the blister, if it was cut off, then it could be returned into stock again. But if it's been removed out and potentially contaminated, then we would dispose of it and we'd have both staff sign and countersign that dose adjustment in the register. So the next scenario is when you're doing a CD check and you find that more liquid oxycodone is left than expected. What would you do in this situation? So this can happen for a few reasons. As I mentioned earlier, if we've got drug companies giving us a little bit more overage, and then that's left in the bottom of the bottle. Other times it can happen from inaccurate medication measurement. So if we're rounding doses, if it's supposed to be 2.5 mils and then we only give 2 mils, for example. Or if there's an undocumented missed dose and that the stock is added back in but not recorded in the controlled drug register. So it's really important that we cross-check the drug register and look at the recent administrations and try to reconcile it. If you can't, then speak to your RN in charge, the pharmacist or the facility manager, and it's likely to be due to the overage from the manufacturer, but we want to rule out any other potential issues or causes from that as well. So transparency is really important in controlled drug management, and if you've got questions, always ask either a senior member or at the pharmacy. So moving on to PRN medications in general, when we look at the prescriptions for PRN medications, we need to make sure that they have, as I mentioned earlier for controlled drugs, specific target symptoms, clear instructions for use, a defined frequency and dose range, and a clear indication as to why it's being used. So before giving it, assess whether the medication is needed, and after giving it, importantly, we need to monitor and record the response and any potential side effects. If a PRN is being used frequently or it's not having the effect and the patient is still complaining, that's your cue to notify the prescriber. Sometimes what starts as being a PRN medication ends up being a regular medication, and that's an opportunity to refer to the prescriber for a review. So when administering, we need to undertake an assessment for the need of the PRN, monitor and record if it had the desired effect, and if it's being administered frequently, notify the prescriber. So monitoring is critical for both controlled drugs and PRNs. You're looking for patterns and changes, so variations in baseline observations like heart rate, blood pressure, respiratory rate, signs of sedation or confusion, and other side effects such as constipation, appetite loss, or behavioural changes. Think about whether the medication is actually achieving the intended effect, and if not, then we need to review whether it's still appropriate or whether there's an alternative or even a non-pharmacological approach that might help. Clinical observation is one of the most important and valuable tools we have in aged care, and documenting those observations, it adds real meaning to the medication record, and it allows the prescriber to review thoroughly and make an informed decision around that medication. So an example here is Mrs. LT. She's prescribed quetiapine 12.5 milligrams to 25 milligrams every 12 hours for restlessness. A 25 milligram dose is given, and it's documented saying the resident is restless and the effect is effective. At first glance, it looks okay, but what is missing now that we know more about PRN drugs? So looking a bit closer there, we haven't documented the specific behaviour. So what does restless mean? Does it mean that you're just really upset? That you're trying to get up when you shouldn't be getting up if you're supposed to be mobilizing it with supervision? Does it mean that you're calling out? Or are you physically aggressive towards staff? So it can mean a huge range of things, and I think it's really important that we're specific with the indications, and then that helps us to guide the monitoring around it as well. So having a dose range is also a potential problem, because how do you know how much to give? Would 12.5 be sufficient, or would 25 be okay, but then it might lead to more adverse effects? So it's probably better to chart it as a single 12.5 milligram dose, and then it can be given BD, and that small second dose can be given if needed, if they're still in need of, if they're agitated. So once we've given the medication, writing given or effective in the monitoring section doesn't really provide us with sufficient information, and we want to look at how we can be more specific around that as well. So things like, did she become overly sedated and sleep for a couple of hours? That would be really useful information to know when reviewing if we should continue this, because that's putting her at an increased falls risk, and there might be better alternatives available there for her. So these details are vital, and without them it's really hard to review whether the dose or even the medicine is appropriate. So that brings us to the end of today's talk. We've covered the 5 R's plus 3 being the foundation to medicine administration, and we've covered how to handle controlled drugs, looking at double checks, making sure that our registers are accurate, and also ensuring prompt reporting. We've also covered PRN medications in general more closely, looking at making sure each dose has a clear indication, and we're reviewing that response as well to allow us to assess the medication accurately. As always, ask any questions if you're unsure. That's what safe practice looks like. And if you do have any questions for me, I will put my email on the slide as well. So if we're following all of these processes correctly, these steps will help protect and ensure our residents, colleagues, and ourselves are safe. So thank you for watching. I've got some references here on the last page, and we'll provide links to those down the bottom as well. Great. See you later. Bye.